This work was sponsored by the Focused Ultrasound Foundation. And let's first take a look at what a type 3 fibroid exactly is, what we are talking about. This is one patient with 3 fibroids, and on the left in the green circle you can see a very dark, hypo-intense structure. That's what we call a type 1 fibroid. And in the blue circle we have a type 3 fibroid, which is very bright and very hyper-intense. And type 2 is intermediate. So very high signal intensity on T2 weighted images. And we say higher or equal to the myometrium, and this is caused by either higher perfusion and or a higher extracellular volume content. The perfusion we can assess with dynamic contrast enhanced imaging. Here you see an early phase. The type 3 is already brightly enhancing, whilst the type 2 is still dark, and that only shows up later at the late phase. And we know from literature and also from our own experiences that these type 3 fibroids show a very poor therapeutic response in terms of volume reduction, quality of life, and symptom severity score, and that they need more acoustic energy, leading to more adverse events. And meanwhile, a type 3 fibroid is a contraindication for HIFU at our institution. And actually that's quite a pity, because 1 out of 5, and in literature even sometimes 1 out of 2 patients has a hyperintense or a type 3 fibroid. So we propose now a new strategy called targeted vessel ablation, which is based on work published several years ago by one of my colleagues. And she noticed that for several treatment cells she needed some higher powers than for others. And in the end, eventually, the non-perfused volume was larger, much larger than the planned treatment volume. So in retrospect, she saw that several of the treatment cells were located exactly on top of some of the feeding vessels of the fibroid. And most likely, she occluded these feeding vessels and had some embolization effect. So this is exactly what we intend to do with the type 3 fibroids, and for that we need quite high powers. And we want to decrease the perfusion. So in the best case, we make from a type 3 fibroid a type 2 fibroid. And we let these high power sonications follow by regular sonications. So that's within the Philips CE marking with a maximum of 300 watts to debulk the main volume of the fibroid. We started with a type 2 fibroid, and as we can see here, based on the wash-in rate, is that the lower part of the fibroid shows very high wash-in rates, so that's where the vessels most likely come in, and the upper part is lower perfused. And exactly where the feeding vessels come in, that's where we planted our treatment cells. And this is an overlay on the non-perfused volume, so on the contrast-enhanced images. And you can see from the dark region that the NPV is much larger than the planned treatment cells, the volume. So here we also most likely had an embolization effect. Then we made a step towards type 3 fibroids. And within the red circle, you can see one of the areas we target with our high power sonications. And this is based on contrast-enhanced images and T2 weighted images that are obtained during screening. On the day of treatment, we only have T2 weighted images. And it turned out that targeting was actually fairly difficult. So if we look then at some of the results, we see here again the non-perfused volume, so the contrast-enhanced images. In yellow you can see the treatment cells. There is some overlap between the non-perfused volume and these treatment cells, but the NPV is very small. And this is mainly due to the fact that the debulking with the larger but lower power cells resulted in poor heating. So the targeted vessel ablation did work in such a way that the NPV is exactly there where we planned our high power sonications. And here we have the second example. There we see that the NPV is a bit larger than the treated volume, but still not large enough for a good clinical response. And this is mainly due to the fact that the targeting is really difficult. So we made a change to the protocol. We now do administer a contrast agent before HIFU therapy, but this means for us with the regulations in the Netherlands that we have a 30-minute waiting time before we can start the first sonication. So far we conclude that the high-power sonications do lead to lethal temperatures and also to a non-perfused volume, and that this non-perfused volume coincides with the planned volume and the location, and that in one case targeted vessel ablation indeed led to a larger non-perfused volume than planned, so there was some embolization, but we need to optimize this protocol to enlarge the non-perfused volume and obtain clinically significant results. I would like to thank my colleagues from the HIFU team and you for your attention.